very much. I request Dr. Harita and Dr. Jason and Karthik.
It's been a privilege to have one of our senior faculty, none other than Professor Krisnam Raju. He's been an outstanding clinician who's from the same Guntur Medical College. We are here today, from MBBS from Guntur Medical College in 1964 to 69, and MD also from Guntur Medical College in 1971 to 74. And DM from All India Institute 74 to 78, and has been teaching in Osmania, and he was the first cardiologist in Siddhartha Medical College, Vijayawada as well, and he has been teaching since 1988 to 2004. He has taught so many of the teachers that we have today. He has been a great personality, and he has been giving services to all the students. He likes teaching, so you can imagine at this age he loves teaching. That is why he came 2 days before for all the postgraduates to be taught, and he travels just to teach. So that is the kind of legend that he is, and he has a very close association with my grandfather, Professor Venkayya Chowdary. He has been with him since MD as well, if I'm not wrong, in Guntur Medical College, and both of them shared a close rapport till he passed away in 2007. So first I thank him for accepting to give the oration of my grandfather, Professor Venkayya Chowdary. So I request him to come onto the stage to conduct the proceedings. And I request our President, Dr. Jason to honor our guest.
Good morning to all of you. I thank APCSI, organizing committee and scientific committee, and the family of Prof. Venkayya Chowdary for giving me this opportunity to come here and deliver the oration which is instituted in his name. A small correction from what Karthik was saying. I started my first lecture class in 1967. Not 88. He was employed as an MBBS student of the first clinical year. I used to take class for postgraduates in medicine and MDs. Because those days for MD medicine, a long case was the neurology. So obviously the questions were mostly on cranial nerves, spinal tracts, muscle groups, gastric, etc. Because I was a gold medalist in anatomy and also physiology. So the MD students finally at exam going wanted to listen about the pathways of cranial nerve, pathways of spinal tract. That's how it started. So it was a long journey. My medical teaching, it goes on. I enjoyed it. Not that I'm a great teacher, but it's okay. And another thing is I knew Prof. Venkayya Chowdary since my student days. So he was assistant professor to Prof. Kodagalaya in Medical College. And I was early MBBS student. So my association with him was from those days, that is mid-60s, till the last minute of his life. Because he was also hospitalized and he passed away under our care in my hospital. So it was a very, very long association. I had also, so we were watching on the screen and everybody was there. Then ventricular restoration. Surgery, cardiomyoplasty was very popular in USSR, Russia. So Dr. Shetty in Bombay, Surgeon Shetty, now another Shetty, surgeon in Bombay. He started doing cardiomyoplasty, learning it from Russia. He claimed some good results, but ultimately it is an abandoned operation. IBC filter was abandoned for a long period of time, starting from France. But now you have a removable filter, so they started using it in limited way. Pacemakers, permanent pacemakers, the BVI, unipolar pacemakers are practically no longer used now. Bipolar, dual chamber is a routine thing. Scope also has disappeared almost. How many cardiologists are using this scope? We can count on them. I was in Cleveland Clinic for about 2 weeks, sometime 1988. There were at least 400 cardiologists in Cleveland Clinic. None of them were wearing this scope. Nobody examined my patient with a scope at all. Now, here neurologists don't have such scope. Gastroenterologists don't have such scope. Surgeons, of course, don't in any case. Many cardiologists also don't have such scope. They don't carry, they don't use us. Some carry but don't use. Right? So what are the new problems of cardiology? I think I may exceed time. I want because I think I see that I'm only half a minute. The new cardiology problems are prosthetic valve disease, right ventricular disease, and then forgotten valve. Tricuspid valve is the important thing now. And changing profile of coronary artery disease, changing microbiology of the infective endocarditis. It was Streptococcus viridans to now fungal to staph, etc. Then new ischemic syndromes like coronary vasospasm, and then you have a normal coronary arteries with classical angina is a big problem. You don't know how to treat them, you don't know how to diagnose them. So that is one of the unsolved syndromes of coronary artery disease. Then you have stent restenosis. We have some options, but still a big disease. Post-CABG graft disease. AIDS, heart disease appear and disappear. During my time in Somalia, we had seen HIV-induced cardiomyopathy, myocarditis, pulmonary arterial hypertension, and then acute myocardial infarction, and then pulmonary embolism, arrhythmias, and pericardial disease. Commonly pericarditis and pericardial effusion. That is more common. So all these things we have seen, but now they seem to have disappeared because HIV itself has come down. One of the greatest medical victories of this century was driving out HIV by more than 50-60%. And radiation heart disease is becoming more and more common. We see quite a few of radiation heart disease, chemocardiotoxicity, then electrical heart disease and channelopathies, PVC cardiomyopathy, LVB cardiomyopathy, etc. And then renal failure, and no, 80% of deaths in renal failure is not because of renal failure, it is because of disease burden on the society, ethical issues, gender differences between men and women, the cardiovascular disease. You know, we have WinCough, we started. I was the one which actually started many years back. Women, once in 2 years, a conference on women heart disease. First 3 years, we did in Nizam's Institute by the chairman of those conferences. Then then fourth one we did in K Hospital. Now, they formed a bigger society with class. Josna is the current. So they are doing the conference, they have a journal of their own, society of their own. So this was originally started by me. Overuse of technology is a problem now. Cardiology training problems. So I don't want to go into details because it would take a much longer time. Personnel supply, because we don't have enough number of people, better. But still we have shortage of cardiologists, cardiosurgeons, cardiology nurses, technicians, rehab people, researchers, etc. And then preventive cardiology has not been given enough importance by cardiologists. So much so, the society, APCSI, said the preventive cardiology should be in the hands of family physician, not in the hands of cardiologists. Because cardiologists have a vested interest in perpetuating the disease. So they don't want to prevent the disease. So it is the family physician who has an interest in preventing the disease. So it should go away from the hands of cardiologists. So these are all the new clinical cardiovascular diseases, which some of them I have talked about: adult congenital heart disease, aortopathies, cardiomyopathies. Many cardiomyopathies now, reversible cardiomyopathies, irreversible cardiomyopathies. You have so many of them. I cannot go Sarfai, right? Fabry's disease, and then beriberi has come back. We are seeing beriberi cardiomyopathy now at least once or twice in a year. And then you have stress cardiomyopathy, so-called Takotsubo is more common than you realize. The first Takotsubo was reported by my group in 1995 from Kamini Hospital, Hyderabad. Even the name of Takotsubo was not there then. It was not published. The first case in the world was published from Japan by Takotsubo. So he published it. But it was in Japanese journal, so nobody knew. So we did not give that name, but we published that case in Indian Heart Journal. The title, Acute Reversible Myocardial Dysfunction Following Surgery. Non-cardiac surgery. Following non-cardiac surgery. That was the first paper published on this thing in India. That was by my group. And later on we saw quite a few of them. It is fairly common. Remember that. And then arrhythmogenic cardiomyopathies, LVB due to cardiomyopathy is different from cardiomyopathy due to LVB. And we have PVC cardiomyopathies. PVC, if they are present, we used to say they are benign. If we did not find any disease, it is not true. PVCs are important, they need to be treated most of the time. And then they do produce a cardiomyopathy called PVC cardiomyopathy. Systemic diseases with cardiac involvement. You have so many systemic diseases, practically all of them will involve the heart. So unless you have a good knowledge of internal medicine, you will not pick them. We have written chapters on that. We published it in CSI textbook on this. And we also have a lecture on this. Chemocardiotoxicity, radiation disease, renal failure, toxic valvulopathies. Like ergot use, anti-Parkinsonian drugs can produce valvular heart disease, cardiac tumors, metabolic heart disease, cardiac transplant. These are the new epidemics. This slide was made 20 years back when I read an article projecting what will happen 20, 30 years from then. This slide was made at that point in time. But that has come true. Heart failure will become the new epidemic. That's what was said 20 years back. We know it true now. Atrial fibrillation. Every day, not less than 6 patients with AFib I see in my service program. Coronary artery disease in the Asians is projected to be going higher and higher. That has become true. Diabetes will jump. It has. It is still jumping. Hypertension. 3% of children, 15% of adults, 30% above the age of 15 years 80% above the age of 80 diabetes. And then obesity, obstructive sleep apnea. This was all projected 20 years back. So I talked about this adult congenital heart disease corrected, how it is becoming a huge problem, unattended, orphan group of patients. So something needs to be done. So these are all the new cardiology subspecialties. I will go fast from here. Clinical cardiology, office cardiology, pediatric cardiology, nuclear cardiology, interventional, echocardiology, electrocardiology, and then cardiac pathology, rehab, oncocardiology, cardiac imaging, transplant cardiology, preventive cardiology, surgical cardiology, which is again subsectionated. So I have some joke which I always say. Cardiology is a great specialty. It's great to be a cardiologist because till you die you can practice, right? If you can't speak, you can pick up one of those specialties. If you go blind, still you can do something. If you are deaf, you can still do something. Till you die, you can do something or other in cardiology. This is not true of many other specialties. So I think just two or three of the important slides. What are the new technologies which are breathing down our neck in medicine, general, and then cardiology in particular, the computers, molecular biology, genetics, genomics, proteomics, bioinformatics, pharmacogenomics, telecardiology, randomized trials, meta-analysis, knowledge diffusion, cardiac rehab, cardiac transplantation. All this was projected, guess, 20 years back. This slide was done 20 years back. Look at that. Allographs we are doing now. Xenotransplant was done. The first xenotransplant was done in Orissa and in Assam. Dr. Balu, the patient died and he was in jail for a period of time. Recently, genetically modified xenotransplant was done in Baltimore. That patient died after 84 days recently because of multi-organ failure. So xenotransplant has become a reality now. It is feasible. So many things, cloning technologies, gene therapeutics, gene silencing, gene suppression, gene balancing, all those things are being done now. But they were projected that this will be the new future of medicine 20 years back. The slide was done 20 years back. So artificial intelligence. Now it is predicted that in 10 to 20 years, doctors will no longer be needed. Machines will be doing all the work what we are doing now with artificial intelligence. I don't know whether it will be true, but it may be true, but I will be happy because I am not there no longer. But some of you will be. Take note of that. Well, that's what we say, but they say it is not required. Artificial intelligence. See, the industry is driving it. The technology industry is overdriving it, and they want everybody to believe that the machines can do everything. Humans are no longer, but they don't realize humans are the ones who actually put the things into the machine. Right? Because artificial intelligence to work, it has to have machine learning. Machine learning to have things, they have deep machine learning. Where do they get to get learned? When we feed millions of our patients and data to that, they learn from that. Who will feed that data? You and I, and all of you will feed that. So big data analytics, mobile technology, robotic technology, nanotechnology, deep machine learning, lab on chip. The IIT Bombay, he spoke to us 5 years back on chip test. They devised a lab on chip. It can do 160 parameters. So smaller than this. So it was a lab on chip. That is so you can just have it in your pocket and go non-invasive. Transdermal, you just flash across the skin of the patient, you get the data. no fluid is, no needle. So that is, I mean, I have seen it happen, but it has to be properly validated, calibrated, and checked and rechecked, etc. So that is going on. Maybe that will be something in your hand in another 5 to 10 years' time. Then wearable devices, already you are wearing some devices, but you have, a coat which can transmit the data on heart rate, temperature, hemodynamics, blood pressure, blood sugar, electrolytes, etc. These are all nanotechnologies. So this nanotechnology is devising a coat. If they just wear it, 24 hours it will send the data to a core lab. And if there is anything wrong, that will give the signal to the operator. They will send the data to the treating physician, so they will deal with that remotely. Telemedicine, electronic health records, then you have cloud technologies. These are all the various things are going to happen this century. Some of that I have talked about it. So genomics, proteomics, bioinformatics. So now the nanotechnology is something which I want you to see with that idea. So smart materials. This nanotechnology, that is 1/1000th of a meter. So this material you can inject into the circulation through the vein. What it can do is, it can give you real-time monitoring of the hemodynamics, real-time monitoring of the chemistry. All chemical parameters, all hemodynamic parameters, all biomarkers data can be transmitted to the core lab continuously. It will be circulating in the body. That is the smart material. Now you also have smart dust and bioassemblers in nanotechnology, but it is still in the laboratory. What it does is, suppose it detects that potassium is high, right? It treats the high potassium. It finds low potassium. It creates potassium. It finds glucose is high. It treats that. It finds glucose is low. It creates glucose. So biofactories, these are all the nano factories within the body. So you don't have to do anything. So these are still being worked out in the lab. And then nano machines. So these nano machines are 1/1000th size. They are smaller than the RBC, smaller than a single cell in the body. What they can do is, they can go wherever you want them programmed to go. They will go and clear the atherosclerotic plaque. You don't have to do anything. They will go there. Or you put a drug on that, it will go to the thrombus and do a lysis, thrombolysis. It is, it will go to the site of the thrombus, specific. And then, infection. You coat it with, send an antibiotic to the nano robot. It will carry the antibiotic to the infection site and release the antibiotic there. Oncology, it carries the onco drugs to the tumor site, release the drug there. So localize the treatment by the nano machines, so they can repair everything, they can mail the drugs, they can deliver the drugs wherever you want, depending on the program. So smart clothing, what I was telling you, a jacket like this thing I wear, all my hemodynamic, chemical data, etc., everything, pacemaker data, everything will go to the core lab and continuously monitor. Then smart cars will carry all your medical, social information. Telemedicine, of course, the first telemedicine program was done by us in 2001, inaugurated by Dr. Kalam, and we have been doing it for Nigeria, Iraq, and Tanzania, Myanmar, and also some centers in India. So we have been doing it, we are still continuing to do it. So telecardiology was first done by us in 2001. These are the nano logos. So cardiology 2020, this was predicted 20 years back. And many of that we have achieved. So look at that. 3D imaging we are already doing, 3D printing we are already doing, holography assisted cardiac surgery it is already being done. So this was all predicted in 2000 year. This was taken from an article which then came in JAC. So in 2050, with this I learned. So what do we predict? What will happen in 2050? This is not a great slide for cardiologists. Very few hearts will get damaged. Which means there will be very little of work for you. Probably most of you will be in the streets. All heart therapy is only preventive. No palliative therapy, no curative therapy. It is only preventive cardiology. Genomic predictive diagnosis. When the child is born, even before born, we know what disease the child is going to get. So, we can start treating the embryo. We can silence the genes, we can splice the gene, we can replace the gene, we can inject the gene, we can remove the gene. We can do everything with genomics. Genomic preventive therapies, that they have already started doing it in China, in Hong Kong, it became a big issue. That guy is in jail now. Because he replaced the gene which gave an immunity to HIV. So this was done without ethics approval, so he is in jail now in Hong Kong. Diet and lifestyle changes no longer necessary. You can do whatever you like. You exercise or don't exercise. Eat anything you want. It doesn't make any difference. Then cardiac surgery. Sorry surgeons, if anybody here in the audience, you will no longer be needed. So there will be no cardiac surgery, no cardiac surgeons. They are not needed. So those of them who survive to that, what they will do, they better earn whatever money they need now, not after 10 years. Okay? Then specialists will be around. Who are the new specialists? Not cardiologists, gastroenterologists, nephrologists, hematologists, endocrinologists. The new cardiology specialists in 15 to 20 years will be genomic, proteomic, medical nanomics, bioinformatic, systems biologists, telephysicians, and robotics. So this is all telecardiology. So this is our first telecardiology, telemedicine unit in India. Dr. Kalam had inaugurated at that point in time. I will not go into this. I will go to my, some ethical statements I am making, just give me a minute. Medical science might actually defeat cardiovascular disease the way it has defeated polio, smallpox, etc. And medical education in 21st century will be very different. This is for the student, medical student of 21st century, you need to be having all these characters. It is not enough if you mug up something, but you need to be much, much more than that. So at the end of it, you need to have a work-life balance. Otherwise, more suicides, more divorces, right? And then a lot of things, bad things will happen to them. So this is a painting. I took a photograph of that in the Museum of University of Padua in Italy, city of Padua. University of Padua was the first university in Europe in the history of the world. It was the very first university in Europe, started in 12th century. That is where this painting was there. It's a very interesting painting. So those are the examiners on the other side. This is a medical student. So the painting was done in 1800. That is beginning of 19th century, first year of 19th century. Painting of the medicine examination in 1800 year. The student is confused. He is looking at something in the jar. And they look at the examiner's face on the other side. Priceless. And nothing has changed in the last 200 years. Still examination scene of the student, scene of the examiners continue to be the same. So this is a painting in University of Padua Medical University. which I just clicked at that point in time when I was visiting. So the three pillars of medical professionalism are expertise, ethics, and service. So I have been, when I saw this monument in Sofia, as the city, the capital of Bulgaria, Eastern Europe, I was there 3 years back. I was stunned and suddenly I realized that I'm in depression. So there was a park there. That park was called Doctor's Park. Park itself was called Doctor's Park, middle of the city, and there was a monument there. There were names on that. These are all the names of the doctors and nurses who served and died in World War I. So there was a monument in memory of them. When I was thinking about India, I haven't found any monument to doctors or nurses. Some roads are named after them, I know, in Mumbai, etc. But where is a monument for the doctors? Where is a monument for nurses or medical staffers? You don't find anyone like that. So I think there is something wrong with this country. They don't realize the importance of the medical work that went on. They talk about it day in and day out, but they don't do anything about it. So I really was very depressed when I saw this thing. The real measure of your wealth is how much you would be worth if you lost all your money. Science has given us power fit for the gods, but we bring to their use the mentality of schoolboys and savages. Will we work in the best interest of society as human professionals? This is the last one. What are the questions in life? How do you act without attachment? Help others without expectations? Forgive without bitterness? How do you maintain peace and dignity in the most difficult circumstances? And how do you find solace and strength in life? And who will cry when you die? I died twice, as a child. I was declared dead in Bapat, but I survived. And in 2013, I had a cardiac arrest, multiple treatments, and then I survived that without any damage. Everything was fine, including my brain, myocardium, everything. So I died twice. Probably I'm the only one who died twice and still living. So I know. And my cardiologist is right there, Anuj did my angioplasty. He was also our student. And then I was declared dead. But then he had the courage to take me into cath lab and do an angio and do the primary angioplasty. And my MRI brain was normal, MRI heart was normal, nuclear was normal, everything was perfectly normal. Not a single cell was disturbed. Pardon?
You are a strong man.
But do you know how many minutes of cardiac asystole I had? Close to 20 to 30 minutes. Cardiac asystole. Well, she drove me to the hospital, but it was me who died. It was he who saved me. Thank you, Anuj, for all that. I'm very happy that I had a platform to thank you for what you had done. This is the 9th year of my third life. So my greatest worry now is that I may never die. That is my greatest worry. So I realized, who will cry when you die? I found for 1.5 years, my students from various cities in the country came, met me, and they cried. Many of my patients from everywhere, for the next 1.5 to 2 years, whenever they come to see me, they will ask, how are you, sir? So instead of me asking them how you are as my patient, they would ask me how I am, and a large number of them would cry for minutes and minutes. So your patients will cry when you die, your students will miss you and cry, some of them, when you die. Maybe your wife may not, may or may not. And your children will definitely not certainly not. Okay? So with that, I end this oration. I thank the organization, I thank the family of Prof. Venkayya Chowdary. I have very, very fond memories of Dr. Venkayya Chowdary. I worked with him. I knew him for almost 5 decades. And finally, of course, in his last moments also, I was there with him. So I thank his family, the both daughters. His second daughter is a cardiologist near Chicago, and his 2 grandchildren are cardiologists. One is Karthik, the other one is in Hyderabad with Anuj. He is also a cardiologist. I don't know him personally. So I thank his family for giving me this opportunity to aid some of my views and also bring forth before you what was cardiology 5-6 decades back when we started out, how it grew, how it is going to be. Whether we will be relevant or irrelevant in future, we don't know. And how the medical education will be, and how we need to conduct ourselves as humane medical professionals. And some jokes here and there, and though they are, meant for fun, but they are seriously right. Okay? Thank you.
Thank you very much.
Wish you a great career, all of you. Wish you a great career ahead of you, and wish you a great day ahead of you. Thank you very much.
Thank you, sir. Thank you very much for the didactic lecture, emotional, nostalgic. We are very happy to hear about Guntur, sir. Many of the things we also don't know. Srikanth is now the professor in Guntur Medical College. Myself, I work there, but still we don't know many of the things which you wrote, sir. Thank you very much.
If you look at the boards in the Guntur Medical College, you will find my name on many of those boards.
Yes, sir.
Because we have some gold medals there. Right? The first thing we do when we go there is to look at those boards, whether the name is still there or not. Thank you.
Thank you, sir. So the next topic will be in Hall B, nightmare session and interesting case sessions are going on. Anybody who is going to present those cases, please go to Hall B. So the next topic is approach to TMVR with case example by Dr. Anuj Kapadia.